thank you everyone for joining. I have some amazing panelists on this call, so I really appreciate people carving out their time during the week to hear from a few of us on what our thoughts are on the future of digital oncology. We are very passionate about the mission around digital oncology and transforming it using digital healthcare. I'm Adam Pellegrini. I'm the CEO and co-founder of Jasper Health, and I'm joined by Dr. Len Lichtenfeld. We also have our members of our clinical team. Holly Spinks is on the phone, and Katie Chavot, who leads our member engagement. So you have a team with very diverse backgrounds in the area of digital healthcare, as well as in clinical and in marketing and member engagement. I started, my passion started in 2000 with the American Cancer Society. It's where I met Dr. Len. When I first joined, I had no idea what this whole online stuff was, the website stuff. If you think about way back when, we just gone through this whole .com thing, 1998, 1999, 2000. And the society was very, and is very forward thinking, and thought we should probably get a handle on this digital health stuff very early on. And so I joined the American Cancer Society in 2000. And it was called Online Strategy back then, not digital health, but really looking at how do we build evidence-based true interventions and use this new thing, the internet back then, to deliver these interventions to a population. I think it's important to note that really my whole observation of 21 years in doing digital health, the one thing that always I come back to is how do you create a foundation of evidence-based, peer-reviewed intervention design and use digital health really as a vehicle, or online as a vehicle, not try to build something and hope that they will come. I've been a part of probably 10 different organizations where we've tried different things, some successful, some not successful. Patient engagement has always been the crux of the problem. How do you get people to really engage on a regular basis? This remained true throughout my entire career. As a matter of fact, in every role I had, be it the American Cancer Society, Microsoft, Walgreens, Healthy Circles, CVS, Fitbit, it always was the what does someone want to do when they're completely healthy on a Saturday? Probably don't want to upload data, and they probably don't want to deal with PHRs. So how do you maintain that continuity of engagement around health and digital health for when people truly need it, but also when they feel that they are in a good spot where they really don't need it, but they may need it again. This is what drove me to Jasper Health specifically, where we really have members today using Jasper today, almost 11,000, that are going through the toughest experience in their life. And so they use it on a regular basis. So this presentation is not about Jasper, but it's actually more about the evolution of digital health in oncology, and just Dr. Len and I's thoughts on where this is going. It's an N of 2. I want to make sure that's really clear. We don't purport ourselves to be the ultimate end-all be-all experts. I mean, Dr. Len is definitely far more the end-all be-all expert in oncology, having led the American Cancer Society for 19 years. But really, these are our observational findings and thoughts. And we just also want to hammer in that where Jasper and others are at today should be directional, not necessarily the endpoint. No one has the true answer of what works and doesn't work in digital oncology. We're all working and striving to figure that out. At the American Cancer Society, I spent years saying there really are no competitors, especially in cancer, because we all have to work together to learn from each other to fight this horrible disease, period. And I maintain that to today. I truly believe we should all be working together to unlock the code of what digital could be used in this area of fighting the disease. I also have said in many different roles that digital alone is not enough. It has to be hybrid care in nature. It should be human plus bot, not bot plus human. That's super important. The story that Holly will share at the end, Holly is our Chief Nursing Officer with huge background in the clinical space as well as digital health. But every Monday, our team reads a story from one of our members, and it hits home how we are helping them, but we are helping them with digital plus humans. And we're not trying to replace the empathy and that's necessary for digital oncology. If anywhere else in digital health, empathy is critical. And I think the future for us is how do we deliver empathy at scale? I think Haymont from General Catalyst wrote a book, and it was really one of the things that stuck out for me is this idea of using AI for empathy at scale. To me, that is so critical so that we can use exception-based care and management so that our clinical teams that truly want to deliver empathetic, very emotion-driven care can do so in a way where it's exception-based, meaning that the people that need it right now get it right now. And the people that are doing just fine using a digital tool right now, they may need it next week. But we should have smart systems that allow us to maximize our ability to deliver that empathetic care, now, next week, and in the future. So we'll progress here. We all know, and for those who don't, for those who aren't engaged in oncology on a regular basis, it's an extremely, extremely expensive and costly disease to the system. To me, it's not just about the cost, but the costs are there, and it's something that we should be recognizing. To me, the personal toll is greater than the costs. That really goes back to why we're doing Jasper. Our consumer side is completely free. Why? Because people need resources right now, regardless of their health insurance, their abilities, any of that. They need guidance now. But the toll on the system is also very, very great. And how do we help reduce that cost to the system while at the same time delivering amazing care to a member or to a patient? And how do we leverage all of those that want to actually help in the most efficient way? And I think that's the other part of care teams and the promise back in the day, Healthy Circles, we built this platform that really focused on care teams and mobilizing care teams around the patient. I still believe to this day that people want to help. They want to mobilize around a loved one, and they want to be able to help no matter where they're at. And so all of that, I think, helps in this big equation of cost, care, and compassion. How do we do all of those things at scale? One of the things I've always spoken about is how does digital really change that game? These are just a few of the ideas and a few of the directions that we know have an evidence base behind them. The pandemic, and Dr. Lennis talked about this often, the pandemic, we saw prevention in a lot of the other areas in cancer care completely have difficulties. Folks couldn't get into their screening and their treatment. So it really prompted this relook at virtual care in oncology. This has really led to that sort of, we should be able to access care anywhere at any time. Now, not everything can be done via virtual. I don't want to ever say that. But there are things that we have found could be done using virtual means. And so it goes back to that concept of triage and hybrid care and how we can actually leverage that the best way in oncology. What's fascinating is in digital healthcare today, we see things sometimes and think, oh, well, this is so new and so next generation. But many of these studies, if you just search, PubMed or some of the other peer-reviewed sites, for oncology and wearables, oncology and virtual care, oncology and remote patient monitoring. There are tons and tons of peer-reviewed journals out there that show that the evidence base truly is there. And so I think what's important as a digital oncology company is that we don't try to necessarily, recreate the wheel. We must build upon the existing evidence base that's been proven out. We must build upon the really hard work that has been done by researchers in the past. And so we think that there are things like remote patient monitoring and some of the work done at MSK around reducing unplanned visits to the ED in the hospital. This was the use of really proactive PRO symptom monitoring, a dashboard, the ability to do interventions based upon symptoms and self-reported symptoms, as well as observational symptoms to specific patients to reduce folks having to go into the emergency department as their first stop, or go into to the ED, then have that ED visit escalate into an inpatient acute visit. These are all things that truly drive costs to the system. Again, this isn't net new idea. This is something that was, published in Harvard Business Review, and really should serve as a lesson for us digital health companies that are looking to evolve the industry. We should be looking at these experts and saying, what worked? What didn't work? It's amazing how much you can learn from peer-reviewed studies like this one around the pain points. What's fascinating and probably not surprising, though, is a common denominator around many of these is the lack of patients, the ability to engage, and the ability to stay engaged, and the ability to constantly report patient-reported outcomes. That has been a common denominator in most of these type of interventions since I started in this industry. Everyone's tried different things. At Walgreens, we had balanced rewards for healthy choices. That really got people engaged in using biometric devices because we gave them rewards. Now, those were extrinsic rewards. And so the next evolution is, how do you get intrinsic rewards for patients that engage in digital technologies like this? One thing that we have learned, and we'll talk about this later on at Jasper, is that oncology is a different disease in the digital area than almost anything else I've ever encountered. It is a very serious disease, and our members, our patients, we call our patients members because we believe the cancer, the disease does not define them, but our members are highly engaged on a regular basis without rewards because it's very serious, and they know they need to keep track of these things as part of their treatment, as well as 10% of Jasper members now sign up net new in remission, knowing full well they need to still, members still need to have that coaching and support beyond their treatment. So I think studies like this tell us where are some of the gaps, but also what has worked and what has been evidence-based, peer-reviewed, and something that can add to the DNA of the foundation of some of these digital health companies. As I mentioned, COVID, we saw an acceleration in virtual care. In my previous role, I saw massive acceleration in virtual care. The deregulation around state licensure truly helped in a very big way, with the spearhead of what I would call, in many of the organizations delivering telemedicine, a hockey stick growth curve. Now, obviously, all of us believe that after the pandemic hockey stick, that there was going to be a return to a little bit more of a pre-pandemic virtual care numbers. Most estimates were 20 to 30% above pre-pandemic virtual care levels. I think that's starting to prove out to be the case. But what I think is more important is that shift in that hockey stick of virtual care adoption during COVID has really changed consumer behavior, right? So there's the clinical side, and there's the business side, and there's the side of who's paying for it. But the consumer started saying, why can't I do this consult to look at this one thing via video chat? I just did it because I had to during COVID. So why can't I do it now? So I think the consumer adoption and behavior change was accelerated by COVID, which to me is as remarkable, if not more remarkable than anything else. I used to always tell the story of my neighbor who lived in a small town in the mountains of Idaho. He had diabetes, and the drive out was 3.5 hours to the nearest hospital. And he always said how treacherous the roads were for him just to go to his doctor to have him take a look at his legs and make sure that the scars and the wounds of his legs are healing properly. And I'm thinking to myself, and here he is Skyping with his daughter in Australia, yet he can't Skype to a town 40 miles away to prevent him from having to drive that treacherous route. And so, to me, that never made any sense. There are absolutely reasons to believe that virtual care will continue to drive a little bit more longitudinal care management virtualization versus what we initially saw in telemedicine and virtual care, which was episodic urgent care type conditions. So to me, I still go back to, though, this idea, people are calling it click and mortar now, and we called it Bridgetal 5 years ago. This belief that truly it's a hybrid approach to digital, specifically in oncology, I think is where we can truly see the next sort of transformation. I think that's going to be very powerful for us. And we've started really building out that construct in Jasper. But this is a model I've believed in for a long time. I've always believed that platforms should be able to connect caregivers and consumers or members, patients, consumer health data together in a very logical way and share that with the healthcare system, the ecosystem that's greater, providing those sort of patient-reported outcome reports, content personalization. We should make this, it should be as easy to manage your treatment as anything else we do digitally on your phone. We don't make it easy today. You hear a lot about silos of health information. That absolutely is still the case. Guess what? There was big buses with the marketing wrap around it at HIMSS 2007 from Microsoft that said Health Vault and Amalga were going to break down the silos of health information. So we've been talking about the silos of health information since since it's all started, really. And even before that, I remember my first job working at Providence Health System in Olympia, Washington, where I was a lab tech, a phlebotomist, and I had to wake up at 4:30 in the morning. I remember this very, very distinctly. And do blood draws so that the providers at 7 o'clock rounds in the morning had all the blood draw information. And I worked in the lab. I sat with the tech and I said, well, why am I waking up at 4:30 and to do this? I mean, it can't take that long. It can't take hours to run these results. And he pointed to 2 different servers that were in the same server room. And he said, it's because that server right there, that you get the lab tech information isn't connected to this server right here, even though they're 6 inches apart. And I said, well, why wouldn't we just connect them with a wire and let the data flow back and forth between the two of them? And that was my first lesson, where he said, Adam, it doesn't work that way. That one wire that you're thinking about, that's a $1 million wire, and we just can't afford it in the hospital's budget. So we have to take the lab tech results from the actual lab techs in the back running the results and re-enter them into this so that the doctors can have them at 7 a.m. And that is why you have to wake up patients at 4:30 in the morning and do their blood draws. That was 1997. So talk about silos of health information. We were still talking about that in 1997. Now today, of course, I'm sure those systems, Providence is pretty evolved in connected health. I'm sure they're working today, but it just shows that no one has cracked the code on interoperability and breaking down data silos. But I will say we are far better than we were, and we should be proud of the industry pushing that forward. It's not great. It's not perfect. We're not done, but we're better than what we were, definitely better than we were in 1997. But I think the other thing I've realized, and something I've known since working with cancer.org, is that it can't just be clinical data that we share between a patient, a caregiver, and the healthcare system. There needs to be a bigger picture. There needs to be a more holistic view of the member, of the patient. That's why we really focus, Jasper's really focused on psychosocial patient-reported outcomes. That's really where we focus, because we can gather the clinical outcomes, but really there is a big opportunity to create that 360-degree view around the patient with the psychosocial data. And before a single line of code was written in Jasper, 2,000 interviews were done with patients and caregivers. The feedback came unanimously back. What we want is, I don't want to just see my lab results. I don't just want to have a copy of my patient record or my encounter notes. I want to be able to share and get help with things around mental health, diet and nutrition, physical activity, more importantly, physical inactivity, and tips of how to increase my physical activity during treatment, and medication adherence, not just the things that we're used to talking about, which, PDC and whether or not you picked up your medication from the pharmacy, but what are the barriers, financial barriers? What are the issues around prior authorizations and copays? That's what really drove it home for me. How do we build this platform that can address these things that frankly seem to be not addressed in a very big way in the industry? And so I think that's really powerful. And I pulled the top 20 interests from the almost 11,000 members currently using Jasper today. I think it's pretty interesting, but probably not surprising for many of us, but the number one was nutrition and meal planning, right? And if you look at some of the other websites, I will say, cancer.org, or if you look at WebMD, nutrition and meal planning is actually big on most chronic disease members that are experiencing a chronic disease list. Mind and body wellness, alternative and holistic medicine, mental health. These are things that frankly, for this cohort of Jasper users really over-indexed in a very big way. They were very low amount were thinking about COVID-19. Most of them were thinking about these things. I do want to call out a couple of things that I think are really important to see, like pet care, right? Dr. Len talks about pet care a lot. But when you're going through treatment, you should think, it really gets very, very tactical. How do I get to my treatment? Who's going to watch my pets? What am I going to eat after I'm done with my treatment? All of these things, this is what drives us every single day at Jasper, is trying to figure out how do we crack the code on delivering these type of, we've actually hired folks specifically for diet and meal planning capabilities now, to be able to talk to our members every single day, either via chat or video, to help them with that. Could we be the psychosocial wrapper around the clinical protocols? I say that every single day, because I think that creates that 360-degree view. I'm very passionate about wearables, as many people know. I had spent a lot of time looking at wearables in oncology. And there was actually a very good article that was out there called, your oncology, basically cancer researchers are passionate about wearables, and this is why. I truly believe ambulation is underrated. This idea that you should get up and walk, maybe not 10,000 steps a day, but 300 steps a day, walk around a chair if necessary to stay ambulated, and the science is there. There's an evidence base behind this. Now, I will say the evidence base is early and it's young, but if it's not organizations like ours and others that are on this call, it's on us to grow that body of work. It's on us to grow that evidence base. One of the things I'm going to be investing in pretty heavily from a Jasper perspective is IRB-based studies on all of our top intervention areas, so that we can actually be contributing to the body of work. I think that's critical. That's why we have Dr. Len on as well, is to make sure that we are looking at those most promising, if not early on. If you look at the American Cancer Society, one thing I learned in my onboarding at the American Cancer Society in 2000 was we may not fund everything, but we want to fund some of the most promising early ideas that could have a game-changing impact down the road. And that's how you most efficiently use the amount of resources you have. That stuck with me, 21 years, that one sort of, I'm so glad you asked session at the American Cancer Society, we called it. But the same as Jasper, we may not be able to try all the interventions, but are there 2 or 3 that we can make a meaningful contribution to the body of evidence around, either for or against? And I think that's going to be important. And how do you use all of this and exception management, this idea of exception-based care, in a way that helps you deliver on some of those ideas like empathy at scale? Some of the original works at Healthy Circles, we use triage dashboards, red, yellow, green, and surveys like SurveyMonkey surveys. This was circa 2009, surveys that would help risk stratify based upon clinical symptoms and biometrics. And so I still believe in some of those core concepts. It was Jim Malt that says we want to deliver better care to more patients at a fraction of the cost, because as a surgeon, he had saw this at a population level. You can't deliver care to everybody all at once. It's just not scalable. To me, how do we use those exception-based care management capabilities in the area of psychosocial? So our triage dashboard, I'm pretty proud of it, has anxiety, depression, ambulation, nutrition and diet as categories for risk stratification. And bigger, broader care management systems that have the clinical data that are really built off of clinical data can actually combine the two. So now you have clinical and psychosocial data on a triage dashboard combined. That's a powerful risk stratification because it not only speaks to the critical clinical needs, but also the emotional and psychosocial needs of the patient as well. And I think that is the future, in my mind, of providing this new holistic care management that we have never done before. And I think that's very powerful. I'm going to stop talking soon because I do want to make sure I give time to my esteemed colleague on here. But going through some of the final sort of data, the idea of impacting on digital monitoring, there's a lot of new data out there that says really even the idea that patients are doing patient-reported outcome monitoring and symptom tracking and sharing that with their provider alone has immense promise itself. We saw the same thing in medication adherence. Individuals setting up reminders for themselves, it's a no-brainer, really. We all use Outlook, and I've said this before, we all use Outlook or some type of iCal for our meeting appointment reminders. And where would we be if we didn't have something popping up saying in 10 minutes, you're done talking, Adam, that kind of thing. Where would we be? Well, we'd be back to the paper piece for sure. I mean, I had a planner, a Franklin Covey planner where I used, and did I always write in my appointments? Probably not, because it was more friction than what I have today, which is these incredible invites that pop up a reminder and say, hey, you've got a meeting in 10 minutes. Make sure you wrap it up. And so same thing being true for things like patient-reported outcomes, reminders, and notifications. There is an evidence base that shows that they help from an outcomes and health perspective, and we want to help grow that evidence base. And so we'll have these slides available for anyone. The last couple of slides I think that'll be important is this idea that engagement can happen. Jasper, I will say, has been an amazing learning lesson for me when it comes to finally seeing health engagement in an area of very serious disease area. In oncology has been so different than any place else I've ever worked. On cancer.org, we saw an immense amount of caregivers actually coming mostly and reading health information and education information and treatment information and helping patients. On Jasper, we skew more towards patients actually using it as a planner to manage their own treatment pathways as well as remission. I think combine the content and the education in a personalized way is the future, and it's showing to work for sure. I mean, 75% of Jasper members actually make it through a 5-minute long profile setup process where they're actually even saying what their concerns are. What are the biggest issues? Diet, nutrition. How am I going to eat during this thing? And people are actually sharing their data. Again, some of the original connected health work I did, we really tried hard to incentivize data sharing amongst patients and caregivers. When you have a serious disease like cancer, that is natural. It's seen as a benefit. It's seen as something it just makes sense to do is share. And so we see high adoption rates in those areas as well. And then some of our outcomes, and I want to be really careful here because as I started this talk talking about evidence-based, peer-reviewed intervention design, it goes back to some of my original work at the American Cancer Society in the workplace solutions area with the former director of the CDC, Dr. Jeff Harris, who now leads the public health for University of Washington. And I used to get all these really great surveys from members or from users of our solutions. And I would say, well, look, we proved it. Active for Life, our physical activity program worked. It's going to save this company money. And he would always say, Adam, remember, these are surveys from users. This is not a peer-reviewed evidence-based study. And I think that set the foundation, that framework in my mind, that we create things in digital healthcare today, and we have good hypotheses, and we may have really good user survey data, comments from users. That does not equal a peer-reviewed study, an independent peer-reviewed study, an evidence-based approach. What it does do, though, is tells you some sentiment of your users. It tells you some directional signals that could lead into an IRB-based study, which is what we're kicking off several IRBs with Jasper, specifically to try to see if there's selection bias. Of course there is, and there's always selection bias in my mind in a lot of studies. If you take it up a level, do you have an iPhone or an Android? There's going to be selection bias there. Do you have a phone? Do you have, so there's a lot of those type of things that need to be ruled out. But from what Jasper members have said, is that they feel like it's helped reduce their anxiety and stress. It passes the sniff test to me, but we want to prove that. They, believe that it helps them with adherence because of the reminders and notification and education. It sounds great to me. It sounds like it makes sense. It's logical, but we want to prove that. But the good news is that the members truly believe it. And that's the starting point that I'm really, really happy about. I can do that. So I'm going to turn it over to Dr. Len really to give his final thoughts or his thoughts on the future of oncology. And then any questions in the chat, Dr. Len and I will be happy to answer. Dr. Len?
Thanks, Adam. And that was absolutely, I'm just sitting here listening to this conversation and thinking about the journey that we have been on for the past, you and I together actually, for the past 20 some years to finally get to the point where we are today, which is truly exciting. And I think a different moment as we talk about digitally enabled solutions to improve healthcare. It's not the first time that conversation has come up, and it won't be the last time. And it really is an evolution. It reminds me of a comment that floats around that says, I was an overnight success. It just took me 20 years to get here, or 30 years to get here. And for those of you who are wondering, yes, I did meet Adam back in 2001, and we did remain friends, and we did remain in contact. And every time he landed somewhere else, I said, there's another notch on the belt buckle. And then, of course, here we have the honor of working together, not only with Adam, but with a number of terrific colleagues. Holly Spinks was mentioned, Greg Orr, and others who are joining the Jasper team. I can't help but think, as I've listened to this conversation, and again, I think Adam did I'm glad it's being recorded because it's one that I want to use to tell people about this journey. But when you go back, it's just been fascinating. And one of the moments that I remember very clearly, it wasn't so long ago, maybe 4 years, 5 years ago, that at the annual meeting of ASCO, the American Society of Clinical Oncology, which is the major cancer meeting for clinical oncologists, not only from the United States, but from around the world. And they had a plenary session. And a plenary session is the place where they present the 4 or 5 leading abstracts from the entire meeting of all the thousands of abstracts they get. And there literally are thousands of docs and others and clinicians, support folks, staff people who are in that room listening to these presentations. And one of the plenary sessions was actually, I think, probably an earlier paper than the one Adam showed from Memorial Sloan Kettering. And they talked about the impact of connectivity in improving the outcomes for patient care. Now, it wasn't anything fancy. It was the fact that they could have an email sent to someone at the cancer center, and the cancer center person would be able to read the email and take an action and either email back or make a phone call or something. Email. And we're talking 4 or 5 years ago, not that long. And here we are in a time when so many aspects of our lives have been digitized or improved digitally. Here we are at a moment where in healthcare, we say, how can we harness that energy? And yes, I'm very well aware about electronic medical records. I'm very well aware of data analytics. I'm very well aware of some very powerful things that can be done, that are being done. They're still investigational, still research, and some that are still a glow in people's eyes. I mean, for example, I listened to this stuff about avatars and coming into rooms and the metaverse, right? The great new thing. I've got to tell you, when I did some work back in the mid-90s, I actually sat in a room with some colleagues, and don't laugh at me. I said, there's going to be a day when you can have a hologram show up on your desk and give you a lecture about what's going on. For those of us who have been around this for a long time, who had dreams and thought about what we could do, it's not new. It's been around, but the reality is today, I do believe, and Adam, Holly, and all of us at Jasper do believe that moment is today to be able to harness that energy and improve the lives of patients with cancer. Now, when we say improve the lives, I think that, again, those of you who are involved clinically know very, very well. And it's not just in cancer care, it's in healthcare in general. We have some serious issues that have to be dealt with. It's not just a matter of how we provide healthcare, how we communicate with healthcare, what I refer to, I'm sure others do as well, as the siloed balkanization of healthcare. But it's the increasing expectation of the healthcare system providing answers for people that are not what we would consider traditionally within a healthcare system. And in fact, some of us refer to it as a non-system of care. And then you start to think about the capacity of digital medicine and what it can do. And so Adam mentioned virtual visits. I happen to have a home in a very remote area of the state, and I'm in Georgia. I'm in Atlanta right now, obviously, as you can tell, not exactly a remote area. But when you think what it means for somebody to be able to care at the point of where they live, not at the point where I work, and it may be something as a follow-up visit where somebody doesn't have to get into a car. Heck, I have to get into a car to drive literally 5 minutes down the street to my hospital where I get my care, my medical center. And then I got to park my car and I got to go in and I got to spend time. And I have 10 or 15 minutes with my clinicians who are excellent. But the reality is that's not necessarily the best way to deliver all of the care. So as Adam alluded to, the pandemic has shown us that care can be modified. It can be different. And there are those out there among my colleagues, among my professional colleagues at every level who say, no, we're going to go back to business as usual. I and the Jasper team, and of course, many, many others, don't believe that that's the case. We're going to have to figure out how we deliver care to more people more effectively. And I don't mean to be impolite or insensitive when I say more efficiently. We need to figure out, so when we talk about care and the newer models of care, a lot of things, as I mentioned, shift onto the clinician. It's not just a matter of me and my medical skill being able to diagnose, treat, and talk to patients, but the expectation of patients and caregivers in oncology is for emotional support, social support, financial support, medical support at the time of need. So if we're successful at Jasper, we can build and offer those tools in a way that was never thought of before, to bring things together, to make it a system of care, not necessarily somebody sitting in my office or next door to my office, but they may be across the country. Think of genetic counseling. Genetic counselors have been doing telephonic consultations and Zoom types of consultations for quite some time. There's only a limited workforce. Think about psychosocial support. Think about pharmaceutical support for copay programs. Think about a platform that brings those opportunities together, that takes advantage of being able to digitize it in a way that may be, in some situations, what I call agnostic to the system the patient's in. That may be somebody from outside that Jasper builds a product. Also giving the option to say, no, wait a minute, that person is within this healthcare system. Or even to refine the point, this person's within this system and that particular insurer, and trying to focus people and move them in the right direction. So it makes it easier for people. Makes it easier for people to get the care they need. Perhaps we can reduce the cost of care. Perhaps we can improve the quality of care, satisfaction with care. Perhaps we really, I've talked for a long time about patient-reported outcomes, and Adam alluded to it. Perhaps we really can ask a couple of simple questions and get an idea of what the status of that person is at that moment. Perhaps we can see through the use of tools like Fitbit, and I've got Adam will be pleased to know I've got my own little Fitbit here. Maybe that monitor will show when I'm having some serious sleep disruption. Maybe it'll show me a cardiac arrhythmia, a heart rhythm disturbance. I'll tell you that even in my own personal life, I've seen, believe it or not, I've seen that I've had cardiac arrhythmias at nighttime based on Fitbit. I've seen someone very close to me recover from COVID and watched retrospectively taking a look and seeing their respiratory rate and their respiratory status and their oxygen saturations changed and improved over time. Now, that's an N of one, but as Adam alluded, I think what's so important, and Jasper has, as Adam said repeatedly, Jasper has made it a core principle to say, these are the tools we have, this is the information we have, this is the research we have, and not only that, not only do we want to implement based on that, but we want to expand that knowledge. We want to be able to tell through, obviously many of you on this call may be very much aware, using augmented intelligence, analytics, to be able to pair that information and find out when a person's in distress and be able to say, do you need help? I've got to say, I've traveled in foreign lands, and I was in Mexico, and I went to a store and I put down my credit card for a purchase. It didn't take 10 seconds for my beeper to go off or my phone to go off. I'm still an old doc, right? It didn't take 10 seconds for somebody to come and make a fraud check on that card, because we have the capabilities, and we all here have known that. I'm laughing, it's not funny, but I had to smile a little bit about what Adam talking about the two systems side by side in the $1 million connection. I actually had a good friend die recently. I don't know if he died because of that, but I had a good friend who passed away because a lab computer and the computer that ordered a test didn't sync. And this person fell off the radar screen of the location where he's receiving his care. He passed away, and after he passed away, it was pointed out the lab test had been lost. The test came back indicating he was a candidate for immunotherapy. Those things shouldn't happen to us anymore. People shouldn't have to wonder, can I reach out and get information? Sometimes it may be checking an appointment. Sometimes it may be looking up a piece of information. Sometimes it may say, I need to talk to somebody. Sometimes it may be, what else can I do to improve my quality of life? We shouldn't have to have people wondering where to go, how to get that care, what's the place that they can trust, which brings up another important point. I talk frequently about the activated patient and the fact that we as individuals, for better or worse, have to take more responsibility for our own care. I will share that even this week in the New York Times, they had, I guess it was last week perhaps, they had an excellent op-ed from someone talking about the problems of being an activated patient. That is, our system isn't providing that support anymore. But I would suggest that we need to be activated patients, activated caregivers. I would suggest that if our system is so overwhelmed with so many demands and too few resources to answer those questions, what are the tools that are going to help us make the experience better? Adam has already mentioned, cancer is a difficult disease in and of itself. People shouldn't have to worry about how their records can be transferred, how they can view their information, how they can get financial help, how they can get the kind of counseling they need at the moment they need it. Jasper has the potential to fill that gap. So I'm thrilled to be part of the Jasper team, along with the folks that we've mentioned before, Holly, who's here on this call with us today, who's a terrific member of the team. I was going to say addition, but she's there at the beginning, so a lot of credit for that. This is a team that cares. This is a team, and I have to say something that I think may have been obvious to all of you. This is a team that not only thinks they can do it, this is a team that understands what they need to do to get it done. And that is a key ingredient, in my mind, for success. So Adam, thank you very much for giving me this opportunity to be part of the Jasper team and also the opportunity to share some thoughts with our viewers this morning or this afternoon, depending on where they may be located. Thank you.
Well, thank you, Dr. Len. And thanks everyone else for joining. We really appreciate the amount of time and the commitment for folks to take a break in the day and listen to a couple folks talk about their thoughts and shared learnings around digital oncology. We will make this webinar available to the public. We will also make slides available to anyone that is interested in looking at the slides and asking questions about the slides. Seeing that there's no questions from the attendees, we'll also give everyone 10 minutes back and truly appreciate those that did join, and feel free to reach out to Jasper. Adam@hellojasper.com is my email address if you have questions. Dr. Len, I will forward to Dr. Len and we will respond via email. So with that, thank you everyone, and I hope you have a wonderful day. Thank you.